We're going to look at different groups or families of medications, starting with the antidepressant family. I mostly use brand names because that's what patients are familiar with. There were the older ones, the tricyclic antidepressants, which had a lot of side effects like dry mouth, drowsiness, constipation, and weight gain, and so we hardly use those anymore. However, they can be very useful. In general, we prefer the second generation products, such as nortriptyline and desipramine, because they have less side effects and are easier to achieve therapeutic blood levels, which can be monitored. They're useful for pain, and desipramine is stimulating, less weight gain, and easy to titrate. Unfortunately, they can be cardiotoxic at higher doses, unlike what came after. In the mid-1980s, Prozac came out, and it was the first of the newer ones. Unlike the older ones, this worked primarily on serotonin. After that came a slew of serotonin antidepressants. All the ones that work on serotonin tend to help anxiety and depression and cause stomach upset when you first start them. That usually goes away. They can cause sexual side effects, which may last while you take the medications, but will go away when you stop. Sometimes they can cause dulling or apathy. The newer ones have less side effects than the older ones. Zoloft, Paxil, Luvox was for OCD, and to some degree Celexa have more side effects, whereas Lexapro and the newer ones have less. Vybrid has additional partial agonist effects at the 5-HT1A receptor, similar to Buspar, that may improve anxiety and reduce sexual side effects. Cerzone, a bit older, is very effective, no sexual side effects, very well tolerated. It's off the market in Canada due to liver toxicity, but is available in the United States. However, liver tests must be monitored closely. Most people do fine with it. Although antidepressants since Prozac are not cardiotoxic, we do have to keep in mind QTc issues. Many medications can prolong QTc complex, especially Celexa, and to a lesser degree Lexapro. Just one of the many reasons we have to keep track of all medications the patient is taking. Common example, Lexapro plus Seroquel. All medications that work on serotonin can cause a discontinuation syndrome if missed or stopped suddenly. Unlike withdrawals from benzodiazepines, this is not dangerous, but it is uncomfortable. Generally, it's in the head and the stomach, described as like motion sickness. Sometimes there can be visual trails and other weird phenomena. The shorter half-life medications, like Effexor and Pristiq, cause this more. However, if people are concerned about coming off, they can later be switched to Prozac, which has a long half-life and is easy to wean. There is one antidepressant that doesn't work on serotonin, and that's called Wellbutrin. Instead, it works on norepinephrine and dopamine, so it's more of an energizer and motivator. It's good for depression, concentration, focusing, but not for anxiety, and used alone, it can make anxiety worse. That's less likely if you add it to an SSRI. It can also help ADD-type symptoms, and Strattera is a similar medication that's used for ADD. Wellbutrin is a potent 2D6 inhibitor, so it will significantly push up blood levels of Cymbalta and many other medications that we frequently combine with it. Our understanding about how we can safely combine and adjust these medications improves all the time, but requires us to keep up and regularly use software that incorporates the science. So in the past, a lot of people were given SSRIs, most frequently Zoloft, which helps anxiety and depression but often caused dulling or apathy. Psychiatrists would add Wellbutrin, which added the spark, and people were good with that. Nowadays, we have SNRIs, which work like a combination of SSRI plus Wellbutrin, all in one medication. In general, they are more potent, but don't necessarily have more side effects. There's no reason to try an SSRI before an SNRI. The longer the depression goes on, the harder it is to treat. Here are the SNRIs. Cymbalta is more calming than most. It is also helpful for a lot of types of pain syndromes. Occasionally, it can be a little sedating, then you would switch it to bedtime. Effexor and Pristiq are much more energizing. Less calming, but still usually help anxiety. Pristiq is the active metabolite of Effexor, like a purified form of Effexor, much easier to tolerate, and it's now generic, so there's little reason to use Effexor. A few people will do better with Effexor over Prestique. Remeron is unusual. It causes weight gain, so that quickly rules it out for many people. But here are the advantages. Number one is it's sedating, mostly in lower doses, 7.5 to 15 milligrams. However, 30 to 60 milligrams is required for the treatment of depression and anxiety. At lower doses, it has heavy antihistamine effects, and as the dose is raised, serotonin noradrenergic effects kick in. If I prescribe it, I warn the patient in advance that if they're too knocked out in the morning, I'm going to ask them to take more so they don't think I'm crazy. Number two is it has no GI side effects. Number three, no sexual side effects. And number four is it seems to work faster than most of the other ones. Savella, which is milnacipran, and Fatsima, which is levominalcipran, are fairly new, brand only, not used as much yet. Savella is approved for fibromyalgia and Fatsima for depression, but off-label both are prescribed for depression and pain. They boost levels of serotonin, norepinephrine, and dopamine, and are also weak NMDA receptor antagonists, which may contribute to the positive effects on chronic pain. Trintellix is considered an atypical antidepressant. It increases the release of serotonin, norepinephrine, dopamine, glutamate, and acetylcholine, and reduces the release of GABA. Some of its mechanisms seem to have pro-cognitive benefits, and others that reduce sexual dysfunction. Those are the antidepressants. We move on to Buspar, which is similar to antidepressants in that you start low and titrate up gradually, and it takes a few weeks to work. However, it really doesn't treat depression and has very mild effects on anxiety. I tell patients it's like a Tylenol for anxiety. Next, we go to the atypicals, and these are called atypicals because they work on many symptoms, including anxiety, depression, hypomania and mania, mood swings, and psychotic symptoms. Many help sleep. They replace the older typical antipsychotics and are used much more widely because they have way less side effects and help such a wide range of symptoms. Almost all medications are metabolized by the liver, so they can all add some risk to the liver. Lithium has mild risks to the kidneys, but the atypicals have a unique risk over the long term of twitches and movement disorder that can become permanent even after the medication is stopped. The risks are low, with the atypicals about 0.7% per year, that's 7 in 1,000, but it's cumulative, so after 10 years, that's 1 in 100. I usually tell patients, family members, others that they can generally take them safely for a couple of years, but should avoid taking them longer unless there are reasons. This group also has increased risk of metabolic syndrome, mostly tied to weight gain. Risperdal was the first of the atypicals, much cleaner than the previous antipsychotic medications. It has some sedation and higher rates of extrapyramidal symptoms. Zyprexa is very potent, very sedating, and causes a lot of weight gain, but has less EPS. Geodon is very potent, sedating, some get EPS, but no weight gain. You do have to worry more about the QTC interval with all antipsychotics, but especially with Geodon. Seroquel is great for sleep, PTSD, anxiety, bipolar, many situations, but weight gain and sometimes too sedating. Invega is like a milder form of Risperdal and also comes in a long-acting injectable, as does Risperdal. As we get to Abilify, there's a change. Abilify has much less sedation, although it can have some, and much less weight gain, although you can still get it. So in lower doses, it can actually stimulate and calm, which works for many people. Also great as an augmentation agent, as all atypicals can be. However, you'll see a fair amount of EPS. Sometimes that goes away with time or even increasing the dose as it becomes more calming, but otherwise we have to move on to a different agent. I will usually jump to Rexulti in that case, as it is very similar to Abilify with less side effects, and it will usually be covered by insurance if Abilify fails. Saffris should be noted as it's useful for sleep without the weight gain, such as Seroquel has. However, there is more EPS. Diphenhydramine, or an antiparkinsonian agent, can be prescribed with it. Latuda can be helpful but somewhat unpredictable in my experience. It seems to be somewhat helpful as an augmentation agent for depression. Fanapt takes a long time to titrate due to blood pressure changes, so I avoid it. As I mentioned before, Rexulti, brexpiprazole, is similar to Abilify aripiprazole, and will usually be covered if Abilify fails. Vraylar is another new agent. I found it very effective and well tolerated for psychotic symptoms, and it should even be tried in clozaril patients. There are more variable responses, however, for depression and anxiety augmentation. All D2 blockers treat mania. Next we go to mood stabilizers, starting with lithium. Some people get freaked out at the mention, but others see it as a salt, so what can be so bad? Lithium pros, it's one of the best documented medication to treat suicidal feelings fairly quickly. It can be helpful as an adjunctive agent to treat depression. However, it works much better for mania and hypomania than for bipolar depression. It's best for classic bipolar presentation versus those with mixed or prominent psychotic features, rapid cycling, or other less classic features. Remember that the goal of efficacy is reduction of episodes, and having an episode on medication doesn't mean that the medication has failed. Cons of lithium are that the immediate release can cause upper GI side effects, such as nausea, and extended release can cause diarrhea. Switch from one to the other if needed. Other than that, most experience no side effects. Those who do, it would be mild blunting, mild weight gain, acne, or kidney damage, or at other times hypothyroidism. If the latter occurs, we treat with thyroid medication, and thyroid returns to normal if lithium is stopped. There are indications that lithium may increase calcium and parathyroid hormone levels. I tell patients that lithium is very safe if it is monitored properly, primarily with blood levels and kidney functions, and it is dangerous if not monitored. I will never forget the patient I saw in training who went 2 years with toxic lithium levels unmonitored. He had kidney failure and severe cerebellar damage. He could barely walk or communicate. Remember, we were taught to aim for steady blood levels. Newer studies indicate that once daily, usually bedtime dosing can reduce kidney damage by leaving some time for washout and regeneration. In general, we aim for 12-hour blood levels of 0.6 to 0.8. Tegretol is a very effective mood stabilizer. However, the side effect profile relegates it to last choice. Severe sedation, as well as induction of liver enzymes, make it very, very difficult to work with. Tegretol is carbamazepine. As we will see below, trileptal or oxcarbazepine is similar without those side effects. Depakote works well for bipolar for both highs and lows. Lithium and Depakote have equal efficacy for highs. Depakote is much better for lows. It is sedating and causes weight gain. It can cause hair loss. Be careful in younger women, both because it can cause polycystic ovarian syndrome, as well as teratogenicity early in pregnancy, if the patient becomes pregnant while taking it. Female patients should be carefully counseled. We aim for blood levels over 95 for acute mania, 70 to 100 for maintenance. Levels given by lab are anti-seizure levels, not the same for mood disorders. Lamictal is probably the cleanest mood stabilizer. Pros, it helps bipolar and unipolar depression. Most people have no side effects. Cons, it's not as good at preventing the highs. It will not treat a manic or hypomanic episode. Due to the risk of Stevens-Johnson syndrome, which can be fatal, dose titration is very slow, and it can take 8 weeks just to get to minimum therapeutic dose, which is generally 200 to 400 milligrams a day. Patients need to be on antigen skin precautions. Also, HLA testing is now a black box requirement before starting this medication. Most doctors don't even know this. At Foresight, we will do HLA testing unless there is clear reason not to. About 1 in 6,000 patients on this medication will get Stevens-Johnson syndrome. They should never again take this medication. About 5 to 9% of patients who take it can get a macular papular rash, which is responsive to steroid cream and antihistamines. They should stop the medication, but these patients can be re-challenged after the rash resolves, titrating up more slowly. About 2/3 of them will do fine. As lamotrigine is better for lows, lithium for highs, consider the combination, which is safe. Next to benzodiazepines, the red box. These are all addictive. That means the possibility of tolerance and withdrawal symptoms. Xanax is the shortest acting, therefore the most addicting and hardest to stop. However, it has several advantages. Primarily, it lifts the mood. It also comes in extended release. Xanax and Ativan work great for panic attacks. Ativan is longer acting and can be used sublingually at half the oral dose. The main drawback besides sedation is amnesia. Klonopin is great for anxiety and mania. However, it frequently makes people more depressed, so I will try to keep my patients away from it. Valium has the best muscle relaxation properties. Next to the off-label group. In psychiatry, we often use medications that work for seizures and epilepsy, as some can help mood and anxiety. One of those is gabapentin, which probably is used more for pain and anxiety than it is for seizures. While we do not treat pain, some of the medications we use can overlap. It is super safe with a very favorable side effect profile. I tell patients it has a big advantage compared to the benzodiazepines. A benzo may work for their anxiety. They walk around with it, but they're afraid to take it because it's addicting. Fairly useless. If they had a medication that was about 60% as effective, in my unofficial estimate, but they could take almost as much as they wanted without being addicted, how does that sound? For most people, it reduces anxiety and lifts the mood. It can actually cause hypomanic symptoms. It can be stimulating, but some people sleep better taking it at night, usually patients who have pain that keep them awake. It lasts only about 4 hours and can be taken PRN and/or routine 3 times a day about mealtimes. For anxiety or depression, usually people would not take it at bedtime. There is a new long-acting form, which is usually not covered by insurance. The most common side effects of gabapentin are lightheadedness and dizziness, which usually resolve when starting and titrating it upward. If the dose is too high, there may be complaints of feeling fuzzy, and the dose can be lowered. Just as with benzodiazepines and many other psych meds that can be sedating, patients should be cautioned about driving under the influence of any medication until they're comfortable with the effects. Based on my clinical experience with gabapentin off-label, patients usually try 100 milligrams here and there, then gradually titrate up. As they see they like it PRN, they have the option to take it 3 times a day and/or PRN. We aim for 300 milligram doses, but some people prefer more or less. While gabapentin often helps depression, I would rarely use it as a solo agent for depression. The reason is that the effects are short-term, so missing doses will keep sending the patient back into depression, contributing to chronicity. The patient will really never get to what I would consider full remission. Trileptal, as described above, has similarities to Tegretol. The main side effect is dizziness and occasionally hyponatremia. Clinical trials with trileptal for bipolar disorder are not convincing. Many psychiatrists do use it and see results in select patients. When compared to many other mood stabilizers, atypicals and antidepressants, it's not as effective for the lows or the highs or the cycling. However, some patients who are depressed have a component of being dysregulated, angry, irritable, and trileptal can hit the sweet spot, so to speak. If you consider the symptom of dysregulation outside of diagnostic category, we can see it sometimes in unipolar depression, often in bipolar and borderline personality disorder. Some who may not neatly fit any of these categories can have difficulties with emotional anger outbursts they need help controlling. Consider trileptal for dysregulation symptoms, usually given routine, but definitely helpful as needed. At this point, I use Topomex only to reduce appetite. I will treat weight and appetite only if it's related to a medication I'm prescribing. Otherwise, I leave weight management medications to primary care physician. Of course, we always consider risks of weight gain from psych meds, and usually avoid those that cause substantial weight increases. We can also help patients with eating and weight issues through counseling, wellness, and lifestyle change, CBT, DBT, and other therapies. Provigil, guanfacine, clonidine are used at times for ADHD as well as other purposes. I'll skip over these for now, except to say that Provigil or modafinil is now fairly affordable through discount pharmacies such as Blink. It has a major advantage over many other considerations in that it increases energy without risk of bipolar switching and usually without increasing anxiety. Next to the stimulants. Speaking of bipolar switching, many patients with ADHD or ADD can also be on the bipolar spectrum. In that situation, the mood disorder must be stabilized before working with stimulants. For now, we break the stimulants down to the methylphenidate versus the amphetamine products. In general, the methylphenidate products work better for the hyperactivity, but can also cause more anxiety. Adderall is the most commonly prescribed amphetamine. It is gentler, less likely to cause anxiety, not as good for hyperactivity. Most of these come in regular, approximately 4-hour, and longer acting, approximately most of the day, preparations. The longer acting differ in proportion of immediate release versus delayed release, so that what time of day the patient needs the effects must be considered. For example, how much is available in the morning versus later in the day. Vyvanse is similar to Ritalin. However, it is a prodrug and is converted in the digestive tract. Therefore, it's less likely to be abused or diverted. It comes in long-acting only and is often covered by insurance. It also has an indication for binge eating disorder and is very effective. The last group are the sleeping medications, which will also be discussed in a separate presentation. Trazodone is very safe and effective for most people. No addictive qualities. Sometimes it can cause morning drowsiness. Ambien is designed for onset in about 20 minutes and usually gone upon awakening. Women may be slower metabolizers and may require lower dosing. If benzodiazepines are about 80 out of 100 on the addiction scale, Ambien is about 35. If a patient is taking it regularly and stops it, they're likely to have a few nights of rebound insomnia compared to the benzos at weeks to months. If people look up Ambien online, they often see the complaint of sleepwalking. This occurs because, unlike most other sleeping medications, this one puts the head to sleep but not the body. People are used to taking a sleeping pill and waiting to feel it hit them before they go to bed. With this one, when it hits them, they fall asleep and they don't know it. Therefore, instructions are to get into bed about 10 or 15 minutes after taking it. This eliminates about 80% of the sleepwalking problems. The additional advantage is that because only the head is put to sleep, the body is not. The body isn't like Jell-O if you have to get up at night, so falls are less common. Ambien also comes in long-acting form, the CR. Lunesta can work in those who don't like Ambien. It's brand only and can have a bitter aftertaste. Sonata is ultra short-acting, either just to help with sleep initiation or if someone needs to take something early in the morning that may last about 2 hours. Rosarum is related to melatonin. Belsomra is one of the newer agents, unique in that it antagonizes orexin receptors, suppressing wakefulness. Silanor is a re-release of the old antidepressant doxepin/Sinequan, which was very sedating. It may not be covered by insurance, but you can still prescribe low doses of doxepin if you wanted to. In conclusion, this presentation cannot cover all medications psychiatrists use. I've left out MAOIs, MSAM, propranolol, and others. Consider medications to target symptoms rather than diagnosis. Cognitive impairment symptoms can cross many diagnoses, as can dysregulation and insomnia. We do want to address underlying causes. Consider diagnosis and FDA indications, but also consider what symptoms are priority to target and choose medications accordingly. Often we can get 2 birds with 1 stone, such as Cymbalta helping both depression and pain. Other times, a combination of medications will work best in order to treat to full remission of symptoms.